as a consultant, you might review them every month. You may even review them every 2 months. And the administration could be given by the nurse specialist as opposed to seeing the consultant, which would bring the cost down for the CCG. Some of the other costs will be a little bit more ad hoc. So the radiotherapy initially you may not need any, but it might be, as I was saying, there's one area that's progressing, but everywhere else is staying stable. You may require some radiotherapy. So I think the cost would probably come down in people who responded, because I think you could be a little bit less intense about the way in which you monitor them and review them.
Okay.
But that would really be largely restricted to patients who achieve genuine stability.
So it's taking your lady 6 years old, the best basis we can have for judging this.
The thing I don't know, and Cleveland may well know more than I do, which is that if we're thinking about the toxicities that which might land you in hospital, I'm guessing you're going to get them. You're probably going to get them early on anyway. And if you've got to 6 months on treatment, for argument's sake, you're probably beyond the window where you're suddenly going to get an unexpected colitis, unless you know differently.
I would agree with everything you said. I have some issues with the table though. It said resources required for the patient every 4 weeks, and then you've got a bone scan 100%, which implies one every 4 weeks. And things like radiotherapy 40%, which implies getting some radiotherapy about every 10 weeks. So I would have some issues with the numbers in those tables.
Okay.
Much too high.
I think that's probably coming from having a short time, in which case if people had 2 and the 8 weeks, they're therefore multi-thousand.
But even still, bone scans, we do, you can do a bone scan any more than once every 3 months, and some of those are way off the mark.
Didn't the trial, I'm sure you said trial paper and results, it said that resources was collected in trials, or so
obviously driven by the protocol.
And they're always going to be higher than what you'd really do.
But surely some of the ad hoc intervention like radiotherapy will be captured in that. That will be captured down as it'll be in one of the safety tables in the appendices. You could get the numbers from that and actually work out a mean that's evidence-based.
So you're suggesting that it would be better to go back to the trial data?
CSRs,
Okay.
look at how many patients ended up getting, because that's the best source of evidence. There's that much radiotherapy over this period of time, there's your rate, and the outcomes linked to it as well.
Yeah, for the curve over time.
To extract it,
just think about it, it might take up.
It might take it, right.
Yeah.
Well, I guess the only events you've got for things like radiotherapy, probably not many, so you can just assume one will be through, probably being something more common, blood transfusion probably is a curve.
And progressed patients need more GP visits, palliative care, etc. Is that fair?
Yes.
People progressing would, yeah.
Yes.
But I guess they'd do that whether or not they're on the drug.
But they probably wouldn't. So, for example, specialist palliative care, if they're on drug and stable, but they're doing less of that. So there's lots of these things that you should be able to get from your resource utilisation from the trial.
So yes, so there was a little bit of confusion about how some of that resource use would be distributed between PFS patients and PFS patients. So some, I could see sort of two schools of thought, that some pharmacists were suggesting, for instance, that some of the progressed patients may not incur some of the higher costs because they've been monitored at the community level, for instance. So is this something that you've come across? Is there something you could comment on?
So there's very widespread variant in practice across the UK. Again, some patients are discharged actually after initial chemotherapy and first-line chemotherapy. There's widespread variation. Some patients will stay on the books and still keep coming for further supportive care and palliative care to the oncologist. Others where palliative care support services are better, they will be discharged to the community. So again, it's very much linked to what we were saying before about their supportive care and the fact that it's carried out in different places. Even within one network, it can be very different from hospital to hospital.
Can I just clarify just a simple nomenclature point, the PFS?
Progression free survival, yes.
Yeah, but to have one column for PFS and one column for PD is supporting matching the nomenclature. And I would avoid the use progression free survival because to me the next box should say OS if it's PFS.
Or PPS.
Yeah.
Okay.
Yes. So I would just change the acronym.
Thank you for that.
Sorry, there is the time dimension here, isn't it? Like you're assuming they're palliative care for visits per 4 weeks, so once every week. But if people are in progression-free survival for 6 years, presumably they're not getting a weekly visit. There must be some time limits on some of these things.
I think that's true. I think if you are on the drug for a prolonged period of time, your palliative care needs should be minimal, otherwise you're not going to have quality of life. So I think that's a very fair point. You'd initially have more of that and hopefully less of it for a long period, and then probably more as the drug begins to wear off.
The way we did it with ipilimumab was because we had the same issue. Previously, melanoma was 8 to 9 months OS, in which you've got a bit of time in PFS, then you're straight to progressive disease, then basically you're dead. It seemed to be in short order. Suddenly you've got people alive for 4, 5, 6 years. It didn't make sense for them to have continuous palliative care visits and costs. So we actually applied it to what it used to be, you had 4 months of post-progression survival. We just shifted that 4 months post-progression survival to the end and assumed it would ramp up at the end. So you kind of went down to a minimal level of support, and then only in the last, so you can do the lookup in the model to say how many people are going to die 4 months from now, and ramp it according to that. So you have the same amount of cost in there, it's probably the right amount, and a more minimal level in between. That was accepted by SMC unconditionally. Nice, gene a few grumbles, change a few costs, but other than that, that went okay.
It's sort of like it's a box on that side.
It's kind of, it's like the cost of dying, it's the cost of leading up to dying. And if you postpone that by a very long time for some patients, then you still incur it. Then you get into Phil's discounting on it, which is even more perceptive on it actually, because there's also the cost of dying. You take that from the King's Fund, it's about 5,000. You take into the hospice costs and everything else. And that's quite a big sum on death that you are deferring. Small benefit on discounting starts to make the discounting numbers look a bit more interesting.
Okay, thank you. Very helpful. Should we move to the next slide?
Yes. I'm happy to sort of flip.
Okay. Okay, yeah, that's fine. Okay, so the next few slides that we're going to be talking about is actually the parametric survival analysis inputs that we've used for overall survival and progression-free survival. So I'm sure it'll generate some interesting discussion. We'll start to see the Kaplan-Meier curves from our registrational trials. The figure we have here at the moment is a graphic of the NICE decision support unit guidance on how to choose the best fitting parametric curve. So the first step would be to essentially analyze the patient level data that we have at the moment based on a January database lock. Based on the data that we received in January, we first, for both overall survival and progression-free survival, checked if there is a proportional effect seen between the nivolumab and docetaxel arm by testing for the various plots, log cumulative hazards, cumulative odds, and standard curves. If the effect is proportional, we then start to do the standard fitting distributions. Within this, we've explored standard distributions and spline-based models. We then look for goodness of fit, and then our last step is sort of visual inspection and clinical plausibility. Within the clinical plausibility, there's really 3 main sources of data that we have in order to sort of validate the curve we have, which is outside of the registrational trial, the 003 study, which provides us 3 to 4 years follow-up, so it gives us a little bit more than what 017 is giving us at the moment. In addition to that, we have the 063 study, which Lawrence described earlier, which just helps us validate against a third-line squamous population, so another source for nivolumab effectiveness. And the last source we have is a SEER data set, which is real-world evidence of long-term survival for advanced lung cancer patients, stage 3B within the U.S. So that is sort of the other source that we have to help validate our curve. If the effect that we see between nivolumab and docetaxel is non-proportional, so looking at sort of the right-hand side of this diagram, there's 2 measures that we could look at. One is adjusting for both shape and scale parameters within the distributions, or alternatively actually fitting independent survival curves for the nivo docetaxel arm, and then from there it follows a very similar approach. We look at the best fitting curve, look at the AIC, BIC criteria for goodness of fit, and look for visual inspection. So I think for the health economist, this should be sort of fairly standard. I don't know if there's going to be any questions on it, but we'll get to overall survival. Oh, sorry. The spline-based models. Yes, that's the next slide.
we have a